Philis-Tsimikas from the US. Thank you, Athena and Harpreet Bajaj, for joining me. I need to thank PeerView for providing all the logistics support and also helping us beautify our slides, if I may call it that way, for this session, and to Eli Lilly for providing the educational grant to support this symposium. Again, there was the QR thing, fill in your pre-event survey. Then throughout the talks, we will be pushing polling questions to you. So please take part into these polling questions, and also you will be able to submit questions using the Q&A button in your app. And voilà, I will go immediately to this. So for those of you who are in the room, please scan the QR code, and then you will be brought to the KNS website, but it's a specific site for this, or the app. It's a specific app for this section. You have a button poll and also a button Q&A, and also a button that brings you to downloadable learning materials. I will immediately introduce it. For those of you who are online, please use the interface on your screen to submit questions. So you can claim credit and access what I just said, namely the possibility of asking questions to the speakers, and also download activity materials by scanning this QR code or visiting this website. You can do it during the talks. You can do it also after the session concludes. And then some publicity for PeerView to follow them on X and yeah. The goals for today are to really understand how basal insulin still plays an important role in the management of people with type 2 diabetes. It is an evolving role. You will see this year at the ADA the presentation of the new ADA ESD consensus, where we will be discussing on glucose-lowering therapies in people with type 2 diabetes. You will also see the role of insulin there. But I think we're now in a very exciting time when it comes to the availability of insulins in the treatment of people with type 2 diabetes, and the once-weekly insulins, I believe, have brought us a lot of information that they are now, in my eyes, a preferred way to start basal insulin in people with type 2 diabetes, because first of all, they reduce the burden in the number of injections. They also are proven to be safe and efficacious. And so to bring these data to you is one of our goals. And then we will also be discussing why people living with type 2 diabetes prefer once-weekly basal insulins over once-daily basal insulins. So, let's start with a question. Have you ever been involved in the care of a person living with type 2 diabetes who was using a once-weekly basal insulin? So please scan to answer. We have 10% who said yes. So that's interesting, because not many areas of the world have now access to these once-weekly insulins, and I, for one, hope that this will soon change, because indeed, in our ADA ESD consensus of 22, there were no once-weekly insulins, so we just could say that the way to initiate insulin in people living with type 2 diabetes needing insulin as a glucose-lowering therapy, our preferred way of initiating insulin was basal insulin. you will discover in June what it says now. But other learned societies who have more recent guidance, the Japanese Diabetes Society propose also specific guidance on use of basal insulin, and also the CDS primary care guidelines of 2025 propose that indeed in many people with type 2 diabetes, when glucose is not under control, it will be important to timely start insulin, and the way to start is a basal insulin. I believe insulin will be here to stay. It will still be, I can tell you that already, it will still be also in the ADA ESD consensus of 2026. Why? Because type 2 diabetes is an inherent beta cell failure disease. Indeed, you have insulin resistance, but you also always have a component of beta cell failure. Otherwise, there would not be a hyperglycemia. And until now, if we look at the evidence critically of people who have undergone bariatric surgery, for instance, but also those treated with GLP-based therapies, it is clear that there's no full protection or reversal of this failure of the function of the beta cell. And so I do believe that now the treatment of people with type 2 diabetes has evolved with agents that are, besides being glucose lowering, also offers some weight correcting effects like SGLT2 inhibitor, or a big weight effect like the GLP based therapies. But none of them, when you critically look at the longer term observations, really have shown to fully protect this loss of the beta cell. So I do believe that we will see still many people living with type 2 diabetes eventually needing insulin treatment. Now, for many, many years, we have all traveled the world to talk about clinical inertia. And this clinical inertia is very obvious when we talk about initiation of insulin therapy, but also intensification of insulin therapy. And there are different barriers to initiation, but especially also intensification of insulin therapy. Fear of hypoglycemia and the reality of an increased risk of hypoglycemia, complexity of regimens, especially when multiple daily injections are involved, but also poor treatment adherence. And again, we as clinicians often think that when we prescribe insulin that people take it, and that they take it every day. Well, there's some very interesting observations from different areas in the world, and I want to draw your specific attention to the top study, the multinational cohort that has been reported by Thomas Danne, where they show that in a multinational cohort of more than 31,000 smart pen and CGM users, that actually 17.6% missed more than one basal dose over a 14-day period. And that missing 2 basal or 4 bolus insulin doses over 14 days was associated with a decrease of more than 5% of the time in range. And so this is quite impressive. We're talking about almost 1 in 5 people in 2 weeks' time missing an injection. Data from the US, data from Western Europe all confirm that indeed adherence to insulin, bolus insulin, but also basal insulin is not 100%. Here again, an overview of the different basal insulins we have at our disposal. We have the intermediate acting insulin, NPH, and then the ultra-concentrated regular human insulin, the longer acting U100 glargine, and then the even longer ultra-long acting daily basal insulins, glargine U300, and the 2 concentrations of degludec. And now we have the once-weekly insulins. And when you put it on one slide, this duration of action, here expressed as the half-life, it becomes very impressive. Indeed, icodec and Philis-Tsimikas have a structure that make them very suited for a once-weekly administration because they have so long half-lives that when you administer them once a week, you build like a plateau of basal insulin. Here you can see the data for icodec, nicely showing the full weekly coverage with a once-weekly administration. Some small differences in the amount of insulin being present, with somewhat higher levels in the first days after the injection, somewhat lower levels at the end of the week, but still enough to give you a nice once-weekly, a full weekly coverage. This is the second once-weekly insulin, Philis-Tsimikas, with an even longer half-life, where now you also have, once you reach steady state, a very flat profile and a fully coverage of the week. Here you can see the structures, very, very different concepts. icodec, a human insulin with small changes with a linker molecule and then a free fatty acid molecule, giving it a half-life of more than 8 days. And then Philis-Tsimikas, half-life of more than 17 days, where you have the two insulin molecules, the insulin molecules linked to an IgG2 FC domain, giving you each of these monomers are linked to, single chains are linked to an IgG2 FC domain, giving you a very big molecule that gives you this very long, very stable profile. Now, this is a slide some of you may have seen. It was a slide I used when I first talked about once-weekly insulins. It was what we as healthcare professionals thought about once-weekly insulin. I remember sitting in an advisory board with many of my colleagues saying, actually, a once-weekly insulin to be used, that will give us a huge risk of hypoglycemia. My dietitians, my diabetes educators said, oh, actually, this will lead to over-insulinization and to dramatic weight gain. But primary care physicians said, oh, yeah, neat, if we have a once-weekly insulin. That's the same as the once-weekly GLP-based therapies that we're now using. And also, people with type 2 diabetes, when you talk to them, people who were insulin naive, when you ask them, what do you choose, a once-daily basal insulin or a once-weekly basal insulin, they say, well, why do you ask this to me? And that's not very surprising. Of course I choose the one injection a week. But I was especially surprised. We took part in the Onwards 4 clinical trial with icodec in people with multiple daily injections, so basal bolus. And so one of my patients I knew for many, many years, when she ended the Onwards 4 study, and I had to tell her that she needed to go back to the once daily basal insulin, she was very upset. And I said, but you inject multiple daily injections anyway. And she said, yeah, but even one injection makes a difference. And so this is the full phase 3 clinical program, both for icodec called Onwards and Philis-Tsimikas called Quint. We have studies in insulin-naive individuals, studies in insulin-experienced individuals with type 2 diabetes, basal only or multiple daily injections, so basal bolus, and both programs also had a study in people with type 1 diabetes. But today we will be focusing on the studies in type 2 diabetes. We will go into more detail with my colleagues on the insulin naive and on the insulin experienced. So throughout the talks, you will be able to scan the QR code again and ask us questions, so you will also be able to do that to me if you have any questions until now. But as said, we will go into a lot of detail when it comes to the phase 3 trials that are available with icodec and with Philis-Tsimikas. So, some polling questions for you. According to the 2022 ADA-ESD guidelines, which of the following patients would be the best candidate for basal insulin therapy? Would it be a person of 71 years of age, no symptoms at all, 3-year history of type 2 diabetes and a hemoglobin A1C of 7.7% under metformin treatment? Or rather, the person of 52 years of age with hypertriglyceridemia, 7 years of type 2, hemoglobin A1C of 8.1, already using metformin and an SGLT2 inhibitor. Or a 67-year-old person with recurring episodes of severe hypoglycemia, 11-year history of type 2 diabetes, A1C of 7.2, again under metformin, and now a sulfonylurea. Or a person of 82 years of age with dementia, 31 years of type 2 diabetes, A1C of 9, under a once-weekly GLP-1 receptor agonist. Or 5, I don't know. Let's see your answers. They changed the order of the patients. But indeed, so yeah, it is the individual who was already on metformin and SGLT2 and not well controlled, where we would think of adding a basal insulin. Honestly, we were discussing these cases before, and both Athena, me, and Harpreet actually were thinking that also the elderly person may well be a person to think of a basal insulin, specifically when we get to the once-weekly insulins. Can I have my next polling question, please? So, in a multinational survey of people living with type 2 diabetes, how many missed a once-daily basal insulin dose within 14 days, reducing time in range by 5%? Was it 1 dose, 2 doses, 3 doses, 4 doses, or again, I'm not sure. That's just to test whether the microphone is working, because I said it. Let's see the answers. Yay, okay. 50% of you got it. It was 2 doses. So thank you for listening to me. Again, if I can get the next slide showing you the QR code again. If you have any questions, do put them into the Q&A function. And then I will go now to my place and invite my colleague, Dr. Harpreet Bajaj from Ontario, Canada, to talk now about the insulin-naive person with type 2 diabetes and how once-weekly insulins can make a difference there. So Harpreet, why don't you come here? And then I will see if there's any questions for me that are burning, or otherwise we take them after you. There are some burning questions. Okay. What patients should not be tried on a once-weekly insulin? We will take that after both speakers have spoken. And then I will ask you the question. How to titrate insulin again? After both speakers have talked, we will come back to that. And I see a lot of practical questions coming. Okay. Is there... Okay. They're all practical. Hold your questions, keep bringing them. But Harpreet, I will not answer them because I know that you will answer a lot of them, and also Athena will answer a lot of them. So please, take the stage. Thank you very much.
All right. Everybody can hear me okay? Yes? It's great to be here in Barcelona, and great to see so many familiar faces as well. So the title of this symposium is Betting on Basal Insulin. You can take it further to say betting on once weekly basal insulins. And it's a reality in many countries, including Canada, where I come from. We've had icodec now for about a year and a half. So June of 2024 is when icodec already became available. So it's already there. And I'll take it back to my first involvement with the once weekly insulin. As Chantal said, many of the people, the gurus at that time thought, oh, this is not a good idea because of the prolonged hypoglycemia risk. I got involved in 2018, so that was the first time that I got to see how this insulin might work. We were trying to come up with dosing titration algorithms for a phase 2 trial at that time. And I thought, what would be the easiest patient profile to begin with in this, for this insulin? It's actually this. So I have the easier task, and Athena has the difficult task. We have good data about it, which is insulin-naive patient, a patient who's failing whatever therapy they're on, and starting a basal insulin, whether once weekly or once daily. What would you prefer if you had both those options available to you? And I must say, I bet on the once weekly insulin at that time. And now, at this time, I have the experience of that in the last year and a half as well. And it's exactly what Chantal mentioned, that if you give the option to the patient who you're treating and say, would you want a once weekly insulin or once daily insulin? Almost everybody would say yes, of course, the once weekly injection. So keep that in mind. If you're not betting on once weekly basal insulin, I hope by the end of this symposium you will be in that group as well. Let's start with a patient case. Jose, Spanish man, we are in Spain, aged 66 years. He has a history of type 2 diabetes, about 12 years. A1C is 7.9%, on 3 pharmacotherapy agents. So you can see metformin at 1,000 milligram twice daily, tirzepatide 10 milligram once weekly, and then empagliflozin 25 milligram once daily as well. The weight is 90 kilogram, BMI is 31, eGFR is 60 with a slight UACR elevation as well. Jose is retired, lives with his wife, and for many years, the doctor has been saying we should think about starting insulin. Jose has been saying, no, that's too complicated. It'll cause hypoglycemia and weight gain, and he's been resisting that. So that's inertia that Chantal mentioned as well, and we've all experienced that when we initiate the first insulin injection as such. Of course, some of them are legitimate concerns, right? Hypoglycemia, weight gain, and some of that inertia is the burden of a daily basal injection that Jose has been resisting. Here's his ambulatory glucose profile. So as you can see in the green zone, it's about 52% time in range, with a large majority in the orange and the darker orange as such, and that's throughout the day. So some of his sugars when he wakes up are high, and throughout the day they go up with meals, of course, as well. So Jose knows that it's not necessarily up to him to control all of these, despite all the therapies, despite the best efforts that he has been doing. That is the progression of type 2 diabetes that Chantal mentioned, and all of us know of that, the beta cell dysfunction that happens with time, with the duration of diabetes as such. So with that, a poll question coming up. What are the recommendations? What are your recommendations for Jose? And let's imagine that you had access to a once weekly and a once daily. I know previous poll, they said only 10% have had experience with a once weekly insulin. So let's change that and say you have access to both of those options. What would you prefer for Jose? Would you, number 1, refer for diabetes self-management education? Would you, number 2, switch to tirzepatide to the semaglutide? and see if that could control his glucose better? Would you add a once daily basal insulin, or would you add a once weekly basal insulin? So those are number 3 and 4 choices. And then would you just maintain the current regimen? This is good enough. Maybe we could try harder. Or something else that's not listed, maybe a sulfonylurea, thiazolidinediones, or anything else that you can come up with. So we have some answers, and most of you are actually choosing adding once weekly basal insulin. It'll be much simpler for sure, especially going from a once weekly incretin injectable agent, right? It's like a step backwards if you think about adding a once daily insulin when you have a once weekly incretin injection. That's the case when we have discussed this with live patients as well. They're like, oh, isn't there a once weekly option that I can use? And that's, if that option were there, what you're saying, what the majority of you are saying, 80%, are saying is that that'll be the option that you'll prefer. So let's go back to the slides. For those of you who said 90% that don't have access to it, maybe you need a little more practical information, and we prepared this practice aids that are available to you to assist in your practice as well, both for insulin icodec as well as insulin efsitora. And we'll highlight throughout the program some of these big components and highlights from these trials. So carrying on with Jose, insulin naive patient that we are talking about, these are the once weekly phase 3 trials for icodec on the left, and then on the right, efsitora, that have been completed and published as such. So you have 3 icodec trials, onwards 1, 3, and 5, minor differences in terms of how they were conducted. And then you have Quint 1 and Quint 2 with efsitora, which are the phase 3 trials. You can see their baseline A1Cs, mostly in the mid-8s. And then the A1C reduction, which was the primary endpoint in all of these trials, looking at A1C reduction in blues. So the darker blue is icodec. And of course, these are not head-to-head, so then you have to compare it to the once daily comparator. So that's where you compare to. So in the onwards 1, icodec reduced A1C 1.55, glargine U100 by 1.35 on the A1C scale, and that was statistically superior, in fact, with a p-value of 0.02. So if you move across, you'll find that each of these, the once weekly insulin got to a better, numerically better at least, or statistically significantly better A1C compared to that once daily insulin comparator, whether it was degludec or glargine U100, or in the case of onwards 5, you could actually choose whichever once daily insulin the investigator wanted to initiate as such. So what were the differences in some of these trials was the initial dose or the algorithm that was used for dose initiation and titration. And here's the cheat sheet on both icodec and efsitora in a treat-to-target approach that you can start. So if patients like Jose who are not currently on a basal insulin, if you were thinking of initiating icodec, the first dose would be a 70 units once a week. If you were thinking of initiating efsitora, if it was to be available to you, the first dose, because of that longer half-life that Chantel mentioned, the first dose only would be 300 units, and then the second dose would be 100 units. And then from second or third week onwards, you would titrate based on that fasting glucose to a treat-to-target approach. So that's the treat-to-target approach that we've learned over the years with once daily insulin based on fasting glucose as well as any hypoglycemia that has happened over the week as such, right? But then the Quint 1 trial had a different algorithm, which was a fixed dose titration. Rather than saying, you know, you have to titrate up or down depending on the glucose every time, they did a different approach, which was a fixed dose titration. So everybody started on 100, and these were insulin naive participants in this trial, QUINT-1. And the fasting glucose target was 4.4 to 7.2 or 80 to 130 milligram per deciliter. So that's in the green part at the bottom. And then if after 4 weeks, so the previous slide, the titration was every week. With QUINT-1, it was every 4 weeks that you got to titrate. If after 4 weeks, the fasting glucose target was not met, in a fixed dose manner, the next dose was increased to 150. If still the fasting glucose target was not met, it was increased to 250 and then 400. And beyond 400, a minority of the participants in this trial needed to go up beyond that, and then a flexible dose pen was used in this trial as such. So that's the approach, which is kind of like GLP-1-like in a way, right? So it's like, oh, you just start whichever your favorite GLP-1 is. With the liraglutide, it was 0.6, 1.2, 1.8. Semaglutide, 0.5, 0.25, 5, and 1, etc. And tirzepatide, 2.5. So similarly, it's a fixed dose approach that was tried in the insulin arena for the first time as such. And the surprising part, I've presented you the A1C previously, which was similar to the once daily insulin. I'll show you the hypoglycemia, which all of us worried about but didn't pan out to be increased at all. The other part of the algorithm that we have to understand is how do we dose up or dose down based on that fasting glucose or hypoglycemia as such, right? So this is the icodec titration protocol that was used in the type 2 diabetes trials. So depending on the pre-breakfast SMPG, the target being 80 to 130 milligrams per deciliter. If that target was there, then you would maintain that dose, or if it was higher, you would up 20 or less 20 if there was a reduction of the SMPG below the target as such. There was also a possibility of a high risk of hypoglycemia participant. If you designated that, then you could go up or down plus 10 or minus 10 as well. And then F-Citora was similar, except that it also allowed the participants to go up plus 20, plus 40, or minus 20, minus 40 as well, with an alternate lower dosing minus 10 or minus 20, and then plus 10 or plus 20 as well, depending on the fasting glucose, how that was. So that's the kind of in a nutshell, how the insulin once weekly in the trials was initiated and titrated as such. And I've shown you the hemoglobin A1C reduction, which was the primary endpoint. How about the hypoglycemia endpoints? So on the top, we have hypoglycemia, which was self-reported based on SMPG or symptoms, etc. And then at the bottom, you have the CGM traffic light, right? So you can see the red part in the trials that included CGM in this insulin-naive participant trials that we've been talking about. So at the top, the first thing to mention in the top row is that the rates in this insulin-naive participant trials is very, very low. How much is the event rate? It's less than 1 event per patient year of experience. So it's very low rates overall. And then again, when you compare the blues to the orange, which is the once daily comparator, they're not increased as such. So majority of these trials, similar rates, not increased rates. What about the QUINT-1 trial, which was the fixed dosing? It's actually lower and statistically reduced hypoglycemia, and we're talking about level 2 and level 3 hypoglycemia, of course. At the bottom, you have the CGM readings, and you can appreciate the small percentages of time below range in the red that are mentioned there. So very small numbers in these trials. The other question that comes up when we have CGM is, how about the prolonged hypoglycemia? How about duration of hypoglycemia? And Chantal mentioned that with the endocrinologists, that was one of the things that we worried about is, will this lead to long hypoglycemia? And we have data that was presented just yesterday from the QUINT trials, where the duration of hypoglycemia in 3 trials, so QUINT-2 in insulin naive, as well as QUINT-3 and 4 in the MDI or the basal switch trials, You can appreciate the F-Cetora, which is in the orange in this slide, versus the degludec in the blue and or glargine E100 in the Quint4. They are similar duration. So about 35 to 40 minutes is what the duration of any hypoglycemia is. This is based on CGM. Similarly, we've also published from onwards 2 and 4 on icodec in terms of CGM data on duration of hypoglycemia. So without belaboring the point, it's basically the same duration of hypoglycemia that you get in any of these trials with once weekly insulin versus once daily. Of course, you treat the same way as well. Then the second component or the second adverse event that Jose and other patients may worry about is weight gain. So what's the weight gain with once weekly versus once daily? That is on the slide in the insulin naive participants. You can see and appreciate they're about the same weight gain, so about 2 to 3 kilograms on an average, which you expect from a once daily as well as a once weekly insulin. So hopefully those 20% of you who said, no, once daily is better, have convinced you that it's the same A1C reduction, same hypoglycemia, same weight changes as well. So why would you favor a once daily injection, 365 injections a year versus 52 injections a year? Now here's some other practical tips around these insulins once weekly. And again, left is insulin icodec, right is insulin F-Cetora. The timing of glucose lowering effect, as Chantel mentioned, may be a slightly different. Icodec, maybe there is a 2 to 4 on the 2nd to 4th day after each weekly injection. There is some maximum effect time. And then during illness or exercise, in the trials, there was no dose reduction that was recommended in the protocols for any illness or exercise, etc. And that's what we've done in clinical practice, at least in Canada as well, without much problems. And then during those episodes, if there is hypoglycemia or if there's exercise illness, you would treat it. You would monitor the glucose and then treat it appropriately as such. Here's some more practical tips around for getting that weekly injection. We know people will forget, oh, I took it Sunday, but then I had to go out, I missed it today, can I take it tomorrow? And the answer is yes. For both of these insulins, they can be administered ASAP if it's less than 4 days from their missed dose as such. And then finally, some more kind of restrictions. I think one of the questions that Chantel asked, who would you not use, is on this slide. Do not use in people who have a history of hypoglycemia awareness, because though unaware people, hypoglycemia unaware people were excluded from the trial, so we need to gather some more data on that. Do not administer more than 1 dose per week, which is, I think, understandable. Do not use to treat decay. Of course, you need a faster insulin. Do not mix together with insulin in the same syringe. I mean, that's understandable. This is not insulin that you'll mix in the same syringe anyway. And then do not use in combination with other basal insulins. Of course, this is the basal insulin. When you're starting, it's very important to help a patient, especially if they're already on a basal insulin, that they have to stop that basal insulin that they were on before you start or switch to a weekly insulin as such. And then there's some outstanding questions which we can discuss during the Q&A, I think. So getting back to Jose, and finish off the case, and he's smiling at this time. Why is he smiling? Because he did get convinced to start on icodec. 100 units once weekly is his current dose. His A1C came down nicely to 7.2% at the 3-month mark, 3-month follow-up visit. The weight did increase to 93, BMI is 32. And you can see that he had 1 episode of level 1 hypoglycemia, and that's about it. And he's happy that his life is still, quite simple as such. And he understands that this is helpful, especially when he looks at his CGM readings. They're much better as well. With that, I'll invite you to key in your questions to this session as well. If the chair, Chantel, allows us, we will have some time for Q&A after this. I'll take you to some more poll questions in the meanwhile as well. So question, 3 weeks after initiating a once-weekly icodec insulin, a person living with type 2 diabetes with no history of hypoglycemia previously has now an average pre-breakfast glucose of 147 or 8.16 millimolars. So with that fasting glucose, if you were paying attention, what dose adjustment would you recommend for that once-weekly icodec? Is it number 1, no change, increase by 2 units, 20 units, or 100 units? Or you say, I'm not sure. You can cheat also with that practical guide that we've given you, right? Okay, that is the correct answer, increase by 20 units. If there was a 10-unit option, you could do that also if you were worried. That was allowed in some of the protocols as well. But of all the answers that were provided, it's 20 units, not 2 units. It does take a little while to wrap your head around. It's not the daily +2 -2 or +4 -4. It's a multiplier of 7, of course, that we have to remember as such. So with that, I'll pass it to the chair to decide what we're going to do here.
Join us, Harpreet. Thank you very much.
Thank you.
Actually, you already responded because one of the questions was on dosing. But there's another very specific question. How do you handle fasting, for instance, like Ramadan? So how do you do it?
Yeah, that's a good question. There's, with the caveat that there's not been a fasting trial as such, right? There have been some insulins, like daily insulins, that have undergone trials during Ramadan. Once weekly insulin, there's no current trial. So without that evidence, what I would suggest is we could do or try to do something similar to the once weekly insulin before prolonged fasting, like in the Ramadan situation as such. And that's what I've tried to do in Canada. I have Muslim patients who do fast for Ramadan, or other people that I treat who fast for other reasons as well. And then the idea is to reduce the basal insulin, which we used to do with Glargine or Degludec, by about 20% or so before Ramadan, about 3 half-lives, 2 to 3 half-lives before. And similarly, 2 to 3 half-lives before that, we could reduce the insulin once weekly as well. So that'll be 2 to 3 weeks before, because you're planning for it and you can reduce that 20%. And I've had no issues. Ramadan, of course, is ongoing at this point, and I've seen some of those patients back and without any concerns or issues as well. So thank you.
Then there's a question that I can answer now. Can you use this insulin in people who have kidney failure? And actually, I will answer in 2 parts. So if you look at icodec with the linker and the free fatty acids, it is also to a certain extent bound to albumin, but again, there's enough binding spots on albumin to deal with people who have severe proteinuria and low albumin levels, so that's not a worry. And also, it has been tested to quite low pre-dialysis kidney functions. Also, F-Citora alpha, no real worry about renal impairment. So that, I believe, is also very important. You skipped the slide on children and pregnant women. And actually, it's also a question whether it is contraindicated in pregnancy, or are there any studies in pregnancy?
No, and I don't believe there will be, because if you realize the fasting glucose targets in all of these trials was 80 to 130 milligrams per deciliter. So not the strict diabetes or glucose control that we recommend in pregnancy as such. So I don't believe it's been studied, and I don't think there is a plan to study that as such. Of course, in pregnancy, the injection burden is still there, and that needs to be addressed. I'm not taking away that, but given that the fasting glucose targets and postprandial glucose targets are so tight, I'm not sure if once weekly insulins are the right.
You also had a crawling baby on the slide I saw flip by. So any data on children?
Not yet, but I believe that's a population that it should be studied on, unlike the pregnancy aspect. I think it's important to reduce the burden in people in pediatric age group people as well, who are of course faced with an injection burden if they're on daily injection of basal insulin, and I think it should be.
With the growing epidemic of type 2 diabetes in adolescents also, yeah.
Yeah, absolutely. So for type 2 is what we're talking about, and absolutely I think it should be studied. In type 1, it's a different ball game altogether. I think all of people with type 1, if possible, should be on AID rather than on any of these insulins.
Yes. Yeah, so today we will not discuss type 1 diabetes indeed, but perhaps we can discuss it after Athena has presented the switchers, namely the studies that have been done with icodec and efsitora in individuals with type 2 diabetes who are already on basal insulin or basal and bolus insulin. Because, there's some similarities there on the MDI people with type 1 diabetes, but let's discuss that after Dr. Philis-Tsimikas has presented. So Dr. Philis-Tsimikas is the corporate vice president of the Scripps Whittier Diabetes Institute in San Diego, California, and was heavily involved with clinical trials using once-weekly insulins.
Yes, thank you, Chantal, and for the great preface from both Harpreet and Chantal. And I was an investigator for the insulin-experienced patients, and was able to see how they felt. And similar to what you've already mentioned, had patients that were very happy to participate and had a hard time when we stopped. So we'll start off with a patient as well. And this is Janine, a French woman, age 57 years old. You can see her medical history here. She has type 2 diabetes of about 8 years. She's had a TIA in the past. Her A1C is 7.9%. She's got a BMI of 29 at 80 kilograms, a little bit of a reduced GFR, 46, and the raised urinary albumin to creatinine ratio there. And the current medications she's on, which can help address a little bit of maybe that kidney insufficiency. She's on dapagliflozin 10 milligrams, as well as glargine U100 40 units, once daily at bedtime. Her work requires frequent travel across time zones. Any of us here probably understand that. She misses about 2 injections per week. And she had recommendations to be put on a GLP-1, but had pretty severe nausea and vomiting, and really said, I don't want to deal with that with my work and my travel and everything, and that was not really an option. So she does wear a CGM, and this is what her ambulatory glucose profile looks like. You can see that her time in range is about 48% right now, and when you look at that curve, really all her numbers are above target, including her morning numbers when she's waking up. She does have some postprandial excursions there. So, something to think about. What are your recommendations at this point, maybe as a starting point for Janine? And this will be a poll. Get out those phones again. Would you add a GLP-1 at this point, or GIP-GLP? Maybe a DPP-4 inhibitor, once weekly insulin, a U200 or a U300 daily insulin, keep her on her current regimen, or something else. You are all going to be pros by the time this ends. Okay, so I saw the DPP-4 inhibitor there, and it's interesting that a few of you commented on that. The majority, though, did say switch to once weekly insulin for some of the convenience. Something else not listed here, maybe at the end, I would be curious to know what else you might consider. Possibly a DPP-4, although really with those high-ish numbers that we're seeing on her AGP, I'm not sure that we would see much of a improvement. Let's see, sorry, can we go back to the slides? Okay, so as Harpreet showed you, you can go to this QR code if you wanted a little bit more details on approaches. But what are the current recommendations for initiating once weekly insulin that most of you selected in someone already taking insulin? And these are the ICODEC initiation and titration algorithms taken from the Canadian and the EU prescribing information. And they divide it up a bit into what the glycemic goals are like. If your glycemic goals are far from target, then you might want to start with a one-time dose to fill the tank, because this is a long-acting insulin, whether you call it a loading dose or something else. And if that's the case, you would multiply by 1.5. You would multiply by 7 first, so your daily insulin dose, whatever you're on, let's say it's 10 units, for example, or I think Janine was on 50. 7 times 5, 35, 350 would be your first, and then multiply that by 1.5. One time, and then you continue on to your multiply by 7 once weekly dose. So 350 thereafter. And then you measure once a week, and you titrate up and down with the same titration schedule that Harpreet showed you. Okay. So, how about Efsitora? Efsitora, this is similar to what they used in the trials because it is not available yet. They added one other element, and many of us are familiar with this. If you are on glargine U300 or NPH-BID, you actually might be on a slightly higher dose than if you were on one of the other daily basal insulins. And so the first question is, if you're on that, then go ahead and reduce that by 20%. If not, then go ahead and multiply by 7. So same sort of concept of multiplying by 7 for your daily dose if you're going to give it once weekly. But once again, if you're a little bit out of target, so in this case using a fasting blood glucose of 120, after you multiply by 7, you are then going to multiply by 3 for your first dose only, and then all your subsequent doses will go back to that first calculated dose, so the 50 times 7, 350. If your target is good, you'll just multiply by 7 and go ahead without that initial starting dose. So, we're going to ask you a first simple question. You are initiating once weekly ICODEC in a 66-year-old man with type 2 diabetes, a BMI of 31 and a weight of 90, A1C 8.4, and despite maximally tolerated doses of metformin, tirzepatide, and EMPA, what would be the initial dose of ICODEC that you would prescribe? So this is a little bit, Harpreet told you about this. So just that very simple, what's that dosing going to be? Go ahead and enter. And if we have the answers. Okay, so this is ICODEC, and ICODEC initial dosing is 70 units. It is the Efsitora that would be given at 100. So I'm glad we asked this just to distinguish that between the two once weekly insulins. We will do a switch case later on. So one of the other questions that I think commonly comes up is, oh, why do you need that first-time loading dose? What's the reason for that? And this is nicely showing the pharmacodynamics. If you compare glargine, which is in red here, and you're giving a dose once a day, and how long does it take an insulin that has a half-life that's much shorter, 18 to 24 hours or so? And you can see it takes about 3 days. On the left is Icodec in blue, and on the right is Efsitora in lighter blue. And what you can see is a similar concept, except it happens over a weekly occasion. So if you don't give a loading dose, it will take approximately what the half-life is, 3 times that, to get to your steady state. So with the Icodec, the dashed line, the lower line, is about how long it takes, 3 weeks or so, before you get to steady state. With the Efsitora, if you look again at the dashed line, it's got a little bit of a longer half-life, so it might take you 4 to 5 weeks to get there. But if you give that loading dose, the 1.5 for the Icodec, or the 3 times your initial calculated dose for the Efsitora, you get up to your steady state much faster. And you don't see some of that escape hyperglycemia. So that is the concept. So what happened in the studies? And the loading doses were used in all the studies, both for Icodec and Efsitora. And these are the switch, basal insulin, as well as basal bolus. So onwards 2 and quint 3 were basal alone, and then onwards 4 and quint 4 were basal bolus. Starting A1Cs around 8%, a little lower for the quint 3. And the A1C changes that you saw against their daily comparator. And what you see here is pretty similar A1C reduction within all the trials. In the onwards 2, which was Icodec, basal switch alone, there was a slightly better and superior HbA1c lowering, and you might see that play a little bit of a role in some of the other outcomes that we'll see here in just a moment. But nice reduction in a group that's insulin experienced. So the next question that of course occurs is, do you get hypoglycemia when you are pushing people down into a good range? And what we saw here, there was no difference in the levels of hypoglycemia in any of the trials. There was a numerically slightly higher in the onwards 2, and again, that was the one that was pushed down a little bit further with superior A1C, but no statistical difference. In the basal bolus trials, there were slightly higher levels, and that's, we expect that you might have a little bit more hypoglycemia as you're treating with both basal and bolus. But overall, when you look at what the numbers and the rates are, these are incredibly low rates of hypoglycemia. Less than 1%, if you look at the CGM readings on the bottom part, less than 1% in many cases, or 2%, so well below what many of the guidelines suggest you should be at for target in insulin-using patients. If we look at some of the other outcomes, such as weight, similar to what you saw in the initiation trials, very similar across all groups, except once again in the onwards 2, where that A1C was a bit lower, and maybe that played a role in the weight difference. Very small weight differences again, but that one did reach statistical significance higher in the Icodec group. Okay, so the next question that gets asked is, what happens every once in a while in patients with insulin? They sometimes forget to take a dose, or sometimes they take double dose, right? What would happen with this long-acting insulin? Is it going to cause harm to a greater extent than, let's say, the daily insulins they're on if you were to do the same thing with a daily insulin? And so there was a very nice study that was done by Thomas Pieber, which took patients with type 2 diabetes. They were placed on either Icodec or glargine to achieve steady state, and then they were given a double dose. This was as part of an insulin glucose clamp. And then they watched to see how much hypoglycemia occurred. They also then gave them a triple dose and compared to see how much hypoglycemia would occur. They then switched them over so that everyone received the same approach with both therapies and looking at the rates of hypoglycemia. And so here is the result of that. It didn't matter whether you were taking glargine or Icodec. There was some hypoglycemia which occurred with this dosing, but there was no difference. And as a matter of fact, in the triple dose, there was slightly more hypoglycemia in the glargine U100 group. So comparable hypoglycemia rates across both with double and triple dosing. How about with F-Satora? And this was modeled rather than in a clamp study. And you can see here, if you model it out with a missed dose, what happens. And on the top is the missed dose, and in the green is the actual glucose values. And this is when you get into longer and longer acting insulins. When you miss a dose or when you add an extra dose, it begins to have very little effect on those glucose values. Now, if you were to continue doing this for long periods of time, double the dose, yes, it might have an effect. But this is showing what it would look like if you missed one or if you doubled one. Very little effect on the glucose values. The other question that was asked, does it matter if you're taking GLP-1s or not? And this was also looked at in both of the compounds, Icodec here, and you can see favoring Icodec on the left, the comparator on the right, and each of these different, the gray, white, show you no GLP use versus GLP-1 use, and in all of those, they're very aligned. It didn't matter whether you were on a GLP-1 or not. The glucose efficacy was equivalent in both those users and non-users. This was also looked at with F-Satora, and you can see that same findings. It didn't really matter if you were with or without a GLP-1. You had equivalent A1C efficacy, and there was no statistical difference in the hypoglycemia rates as well. Okay, we're going to finish up in the studies with one other interesting combination. We have once-weekly GLP-1s. The question is, now can you combine that with a once-weekly insulin, and would that be effective? And I think we saw in many of the studies previously with the daily insulin combinations that were done that there were some remarkable improvements in glycemia with less weight gain, with less hypoglycemia, and that's what this study looked at. This was a combination of Icodec plus Sema against Icodec alone in some cases, against Sema alone, and then against basal bolus therapy in this combined series of trials, 1 through 3. So you can see that in all the trials there was either greater reduction in hemoglobin A1C or equivalent in the basal bolus therapy trial. And then if you look at hypoglycemia, you, as we expected, have lower hypoglycemia rates with this combination of ICO-SEMA, where you are getting superior glucose efficacy. The CGMs show very low rates of hypoglycemia overall, and your weight is better also, except in the one case where the comparator is SEMA, and you would expect that if you're adding a little bit of insulin and you're comparing that to SEMA alone, you'd expect that you wouldn't have as much weight gain in the SEMA group. So, a really nice series of trials in people that are insulin experienced overall. Here's your polling question. A person with type 2 diabetes has recently initiated once-weekly insulin on a background of metformin, SGLT2 inhibitor, and GLP-1. During titration, they experience a nocturnal hypoglycemia, which was identified because they were wearing a CGM. What dosage adjustments would you make in this person? Would you reduce the insulin and the GLP-1? Would you reduce the insulin alone? Would you reduce the GLP-1 alone? A once-weekly insulin should not be combined with GLP-1, or I'm not sure. Yeah, 100%. My gosh, you guys are good. All right, that is correct. We could go back to the slides. So another common question that has come up. In some cases, this is now available. What happens if our patient lands in the hospital? Or if they're going in for a procedure? Today, how do we manage that? Today, if they're on a daily insulin and they're going in for a procedure, I'll usually tell that patient, reduce your daily insulin by 20% the night before and go in. In some cases, you might even reduce it by 50%. But if someone is on a once-weekly insulin, what should you do, and is it dangerous? And I'm going to start actually with the far right side of this slide first, because this was first looked at in the trial results, in the study results. And there were people that were admitted to the hospital for other reasons. Someone with type 2 diabetes might land in the hospital. And in one study, in the icodec studies, they were able to aggregate the reports to see, did these patients stay in the trial? Did they have any significant hypoglycemia measured on the study device? The point of cares from the hospitalization could not be captured. But if there were any study device captures with the hypoglycemia, and there was no increased rates of hypoglycemia there. The majority of the patients stayed on their dose of icodec and completed the studies, so it didn't adversely affect their retention in the trial. So the middle box I would go to next, from a practical perspective, because this hasn't been really looked at in a prospective trial, what would happen in an emergency situation? And we could use this experience that came from the trials, and you could say no dose adjustment, but you're going to look at the blood sugars in the hospital, and if they go low, you're going to treat them with some glucose, maybe intravenously, or if they're high, you're going to add a little bit of insulin as well, probably correction dose insulin and maybe some meal insulin. The Canadian groups, which have this now available, came out with some recommendations as well. And the recommendations were, what if you know you are going for a procedure in about 3-4 weeks? Should you change that dose? And it's a little bit like what, Harpreet, you were talking about with Ramadan. You know this is coming, you can prepare the patient, and you can make some changes. And this is what the recommendations say. So you could discontinue the icodec 4 weeks before or the F-Satora 8 weeks before, and then switch them to daily insulin. They go through their procedure, and then they resume their once weekly again. How might you do that switch? And we did this switch at the end of all the trials. We did switch them back to their basal insulin. The way we did this was we stopped the once weekly, no basal insulin for 2 weeks, and then we started checking the blood sugars. And if the blood sugars were rising above, the fasting blood sugar was rising above 130, 140, then the basal insulin was resumed. And you could resume it at whatever your weekly dose was, divided by 7, the exact opposite of how we started it at initiation. And then go ahead and titrate thereafter. So that's an approach to peri-procedures. Finishing up with one other question that comes up. How were patients satisfied with this, their quality of life? And I think I started with this. The patients were incredibly happy, satisfied with the treatment, and this showed up in all the questionnaires, the PROs that they were completing. So, Janine, what happened to her? Follow-up visit at 6 months. Her A1C is now 7.6%. Her weight is up just a bit. She's now on icodec U700, 227 units once weekly. She's satisfied with her once weekly basal dosing and has missed only 1 dose since initiating 6 months ago. So what happened to her CGM? She was 48%, if you remember. You start this, and she went up, 57% time in range now. Are you happy with that? What would you do next? She definitely did better. She has only once a day dosing. There may be a few things you could do. But if you look at this list, what would you do? you go ahead and titrate that basal insulin up? Would you add a bolus before that brunch? Do both? Add a DPP-4 at this point? Maintain current regimen, or something else? And if it's that something else, I want to hear about it afterwards. Interesting. Okay, most of you said you would increase the basal insulin. Can you go back to the slides? I just want to go back a minute to the AGP. So you could theoretically go up by another 20 units, maybe try and bump that fasting down a little bit further. So I can see where that might come from. But I do think also there's definitely that postprandial excursion, and I'm wondering if she's a little bit insulin deficient and may need just a little bit of bolus as well, especially with that midday meal if it's a heavier meal. So I could do either one, and we could see how it goes. That's part of the art of treating our patients with diabetes, right? Okay, let's go back, and I have one more question for you, for the mathematicians in the room. Person with type 2 diabetes who uses 50 units of once daily U300 glargine, A1C of 8.1%, has a fasting glucose of 142, and is enrolled in a clinical trial for insulin efsitora. What is the first dose, that initial dose, that this person would receive? Okay, spread out a little bit. So this person is already on insulin. So the 100 units of efsitora we said is for the person that is starting for the first time. On no insulin, you would give them 100 units. This person is on 50 units, but it's glargine U300, which sometimes you dose a little bit higher in order to achieve your fasting glucose target. So the first step is reduce that by 20%. So 50 units, reduce it by 20%. 40, right? Then, it's a once weekly insulin, so multiply it by 7. 7 times 4 to 80. And it's the first dose only, multiply it by 3. And the answer is 840. So your first time dose, 840. Your subsequent doses, 280. Okay? All right, this is your opportunity to ask any other questions. I'm going to turn it back over to Chantal. Thank you so much.
Thank you, Athena. Do join me. Actually, there's a question on dosing that I will immediately ask to you and Harpreet. So, I mean, this whole concept of adding loading to fill the bucket or, fill the gap, would you do that? Question number one, I will ask to Athena, in case you have a history of severe hypoglycemia already before, would you do that loading dose?
Yeah, that's a good question. I do think in practice, we might have a little bit of leeway in how we approach this. And I do think in practice, I probably would not do a loading dose or that first time multiplied dose. It will take you a little bit longer to get to your target. I think I showed you those modeled curves. It might take you 3 or 4 weeks to
fill up that tank. So it means someone might escape a little bit and run some higher blood sugars at that point in time. So.
And we have trials that have been performed where they tested whether the loading dose is needed. So we'll see those in the very near future. But you, Harpreet, you have a vast experience in day-to-day practice. So do you sometimes not do the loading dose?
Yeah, so what I end up doing in my practice is individualize which patients I do a loading dose or a first-time higher dose versus majority of the people I don't do a higher dose for the first week. And the reason is I actually delve into this or go deeper into this and ask them, are you missing at least 1 or 2 injections every week of your daily injections of basal insulin that you're supposed to be on? And sometimes they'll sneakily say yes, maybe once a week, or some will be upfront, oh, I take it maybe half the time or something, right? And then I'm not even multiplying by 7 in those people. Of course, multiplying by 7 would give them the daily dose that they would have taken. So you don't even want to give them that 7 multiplier, leave aside the 50% extra for icodec that is required or done in the trials. And so I would multiply by 3 or 4, and that'll be my starting dose of the icodec. That's my current practice. Whereas some other people, so individualized, some other people maybe my A1C is this, 6.7. My fasting glucose is right within target. I never miss any single basal insulin. And in those people, I do actually use a 50% extra for icodec at this point. And I've had very good experience with that, no untoward problems. Now, with that patient that you mentioned who had a severe hypoglycemia, of course, you'll have to individualize it, maybe not do a 50%, maybe a little lower than that as such as well, maybe a 20%, just to get the long half-life problem for the first 2 to 3 weeks out of that zone as such, right?
Yeah, and then another question on the dose of the bolus insulin, Athena. So you seem to have, with these once weekly basals, less need for bolus insulin. So combined with the GIP, and other combinations, will we see the end of basal bolus in type 2 diabetes?
I don't think we will see the end completely. You showed your curves at the beginning that there's a decline in beta cells, and we know that in certain numbers of people they'll continue to decline. They are going to need a bolus dose of insulin at some point. But with that said, I think that we can use the GLP-1s, the SGLT2 inhibitors, and even maybe a DPP-4 to an extent for some postprandial control, and you may never end up needing that bolus insulin.
One additional practical point, if I may, if you're switching a patient from daily to weekly, and you've been telling them for many years that you need to add a bolus insulin for that brunch in your patient case, Janine, but they've been saying, oh, I cannot take 2 injections every day. But now when you offer them, oh, this is once a week, now will you take a daily bolus because that's what we think we need? They're actually more apt to taking that extra bolus injection as well in many such cases because they're not injecting 2 times every day as such.
Can I just add one other thing that from a practical insurance perspective in the US, once they're on insulin, we can get coverage for a CGM. And
you read the question. Oh. It's exactly that.
So if someone can be placed on a CGM and is visually seeing what their numbers are, it might change behavior enough that they go out for their walk, they do something else, and that might take care of the postprandial rise as well.
So the question was, do you use CGM in these individuals? Do you use CGM, Harpreet?
Yeah, luckily in Ontario it's the same thing. So as long as somebody's on insulin, any insulin, a CGM is recommended and covered as such. So that's a bonus. I think it opens up people's eyes as well as helps the healthcare provider figure out where the problem is and helps titration, change lifestyle, or add appropriate additional pharmacotherapy, whatever that may be.
2 practical questions. First of all, the site of injection. Does it matter with these insulins? Abdomen, arm, leg?
So at least with icodec, I know there was a study that was done with different sites, and there was similar kind of effects that was done. And I'm sure it's the same with Efsitora as well. Just like with any insulin, subcutaneously injected, so anywhere that has subcutaneous fat depots would be okay.
And then another very practical question, the volume. You know, these are big units we're talking about. Is the volume an issue, Athena?
Yeah, it's U500, U700, so these are not, the volume essentially is the same as that of the daily. It's just that they're more concentrated, and that's how we get to the higher doses.
And people have not complained to me that they're injecting a higher dose with icodec and feel it.
Okay.
Yeah.
And also in the trials, there were no abnormal site reactions. So here's now the opposite question. Would you ever use a weekly insulin without a CGM? In our country, there are no recommendations for CGM for people with type 2 diabetes without bolus. So can you use it without CGM?
I think you can. I mean, we still have finger sticks if in those countries they allow a finger stick, and I think you can get a pretty good sense of where the blood sugars are going, and you might be a little bit more conservative if you don't have the CGM in testing, and in titrating a bit, but certainly you could. And I think, Harpreet, weren't you part of a study that did intermittent CGM? So
yeah, in most of these studies, so in all of these studies, actually the SMBG was the driving factor. CGM was just a part of assessment and such. So SMBG was how these insulins were studied. And then another point I want to bring in is from my clinical practice, even though insulin, as soon as you start insulin, CGM gets covered in Ontario, in Canada, but still there are some people, no matter how hard you try, they will not use a CGM. They don't want it to show or whatever the reasons may be, right? And then I have had many patients who have started once weekly insulin with just finger poke, and it's the same as once daily insulin. You titrate based on the finger stick, and then they check if they feel any hypoglycemia symptoms. So you do it the same way as you would for a daily insulin.
Yeah, and also the studies were titrated indeed on the finger prick, and some of the studies even didn't have intermittent CGM. Actually, there's another clinically relevant question. If you have injected, it's the opposite of what you discussed on how to switch from once weekly back to once daily. Here is the practical question. If I have injected, or the person has injected degludec in the evening, can you start the next morning already with your once weekly insulin, or what would you advise?
Yeah, interesting. I mean, that's a case where you might want to start, but without a loading dose and see.
If you've already got a long-acting once daily, ultra-long-acting once daily insulin on board.
Yeah.
Yeah. On the other hand, yeah, still you have a long ramping up period. Huh?
Right.
Excellent.
I mean, I might also consider just skipping the next day and starting the following day too. You might be okay with that.
Yeah, we all three, when I showed the ideal person for once weekly insulins, we were all, perhaps the person with dementia, 80 years old. So I know you in practice, people who are being injected by others, by carers, by professionals. Is that also a situation where you use once weekly?
So unfortunately, at this point, the public coverage is not there for icodec in Ontario or in Canada. But having said that, public coverage is for people who are 65 years or older, right? Having said that, there are people who depend on their caregivers, their family members, their friends, their neighbors, maybe a visiting nurse who injects that insulin. It makes complete sense to prefer these agents, once weekly injection rather than a daily injection. And having said that, it's not covered, there are some patients whose caregivers are willing to pay for a once weekly injection rather than having to go to their mother or father every day to inject because of that concern as such as well. So right now, I do have some patients whose caregivers are injecting once a week, even though it's not covered in their public coverage.
The end of our symposium. So here we will again ask a few final polling questions on your devices, so do scan this QR code. Now, these are the conclusions, the key clinical takeaway messages, I would say. So people with type 2 diabetes who can use once daily basal insulin can use once weekly basal insulin. Initial doses and titration steps for once weekly insulins are usually 7 times as large as for once daily insulin. And once weekly insulins can be used with the same glucose lowering medications as once daily insulins. Again, I want to remind you, you can take these clinical recommendations also from the app, download them on your device for further use. So I would like to thank my colleagues, Professor Philis-Tsimikas and Bajaj, for joining me here discussing the once weekly insulins. I would like to thank you for joining us, and please, again, you can scan here the QR code to go to the downloadables for you to use afterwards. Again, please go back to the pre-event survey now that you have had the event, so that we can evaluate the impact of our symposium. So I want to thank again peer review and also the Eli Lilly company for allowing us to organize this symposium, and you for attending. Thank you very much.